It's wonderful to be here. I'm Jeannie Kelly. I am an associate professor of OBGYN here at Washington University in St. Louis. I'm a practicing clinical maternal fetal medicine with a research and clinical interest of treating pregnant individuals with substance use disorders and really trying to explore how to improve outcomes and increase treatment success through implementation science. And I'm thrilled to share our experiences in our publications regarding urine drug testing during pregnancy, called this Care Before Consequences. And this is really a story that I'm going to tell you about how we started thinking about this here in St. Louis and kind of where we are with kind of this journey. I have no disclosures. So, my learning objectives for everyone here is to define the potential benefits and harm of peripartum urine drug screening, describe how select order indications can really drive low value and equitable screening practices, and then help everyone kind of identify effective and scalable strategies to improve fairness in peripartum urine drug screening. So, before I get started talking about testing, I think this is a pretty friendly group in of women in addiction medicine. But I've given this talk to pediatricians, obstetricians, a huge range of people who don't have the lived experiences of treating this population of patients. But I do think it is important to start with three central truths that we all agree with universally as practicing clinicians, scientists, researchers, et cetera, which is one, that child abuse and neglect does result in morbidity and mortality. Two, people who use substances in pregnancy suffer some of the most extreme stigma that we have in medicine and clinical care. And three, that all medical providers are really here to seek to help and not harm the patients that we all serve. So I think it's really important when I give this talk to give those sort of three central truths and kind of ground ourselves in them. In the same breath, I think it's really important when in the medicine we practice, we sometimes have to think about, are we actually abiding by these three central truths in everything that we are doing in our clinical care? I probably don't have to go too into depth about this, but national organizations are generally in agreement when it comes to screening for substance exposure, addiction, dependence, and use during pregnancy. Verbal screening is really the preferred methodology and is universally implemented during prenatal and obstetric care. Verbal screening is preferred because it's easily administered, it's more acceptable to the patient population, it's economical, it's comprehensive, and it provides longitudinal and clinical information to help you diagnose actual use disorders or addiction or other sort of clinical diagnoses that change management. Biochemical testing is not really your first line ever in terms of screening as recommended by these national societies because, one, it's costly for accurate testing. There's limited panels, right? We think of urine drug testing, urine drug screening, like one of the most common substance of misuse during pregnancy, which is alcohol, is not part of that panel. It only gives you a snapshot in time, right? It tells you what has been recently exposed. So positives and negatives do not a pattern actually make by a one-time snapshot. There's really, really tough consequences of both false positives and false negatives. Those consequences include really impactful legal implications, and we'll talk about these in depth a little bit, and really can undermine trust, especially if consent is not a comprehensive informed consent is not part of your biochemical testing pathway. So why does urine drug screening still exist, right? And so I think, for anybody who takes care of an obstetric population or any clinical care that you do, we ask like why have you previously sent a urine drug test or a urine drug screen on any patient that you take care of? And these are kind of the answers that we get back from both the maternal and the neonatal and sort of general clinical side. So, oh, this will identify neonatal risk of withdrawal, dependence, exposure for future monitoring and management. Or This will guide our clinical care, right? If we can tell that mom has been exposed to a certain substance or baby has been exposed to a certain substance. One that we hear a lot about is like this is way that we can like identify moms who are at need. We can connect moms to treatment, and this is how we identify, helps us identify those who are most in need. Obviously, very tightly tied to this talk, we have to be able to detect the substances so that we can protect the kids. Like we really, really have to be careful, and any substance exposure, like we need to know to protect the kids. And for a lot of folks, we have to meet the reporting requirements required from the hospital, the state, the federal levels. So I think this is a great study that I really like where they looked at a large hospital system of 60,000, over 60,000 deliveries to understand kind of what the pathway actually was. Like, do those results that we just, or those reasons that we send urine drug screening during the peripartum period, do those actually pan out? So this was, 60,000 deliveries. And out of that 60,000, there were 80 sort of unexpected positives. So most of the urine drug tests that they sent, mom was like, hey, I'm using cocaine. And their urine drug test came back positive for cocaine, right? So these are really like the unexpected positives that came back from this cohort. You can see here that, it's not really great at connecting patients to care. A minority get referred to treatment. A minority are initiated on treatment if it's a positive opioid in their urine drug screen. A minority come back for their postpartum visit. Postpartum health, any postpartum, sort of follow-up is really quite low. So the data does not suggest that this screening or testing methodology is actually effective to identify or connect moms to treatment and really does not help sort of ensure that there is a connection to medical care in the postpartum period. But what the test is really, really good at is that 90% of these moms had a CPS or a Child Protective Service report filed on them. And that's really the core of this is that, this has huge legal ramifications for both mom and baby after the time of delivery. And I think it's really important also to look at who gets a CPS report filed on them. I think probably surprising zero people in this room. Again, when we break down, this is looking at, 2.8 million CPS reports filed over this sort of nine-year time period and kind of levelizing it by, birth rate. You can see that number is really increasing. This is filed by medical professionals, so clinicians, staff, social workers in the hospital. You can see that number is really increasing, and it's really dramatically increasing for Black, non-Hispanic individuals. And I think for folks in this group, this is not a surprise. We know of the disparities that do exist when it comes to legal ramifications at the time of the delivery encounter. I think it's also really important to remember, and again, probably not something I have to tell this group, that substance use and substance exposure is really of equal percentiles throughout all the races, right? It's not that like this is a huge group where it's stratified by race, like who uses and who doesn't, or who needs CPS or who doesn't. This is a result of the system that we all currently work in. And I love this quote, and it's a little devastating, right? To remind ourselves, every system is perfectly designed to get the results that it gets. And so this is by design, kind of what the results of our system currently are. And I think it's important when you see these results to think, what can I do to redesign the system so it doesn't give me this result? And is this really the system that I want to be working in, right? So this is, as many projects in OBGYN start one dark night on labor and delivery with our social worker, just really devastating case of having to call CPS, for a family that she did not feel like she had evidence of neglect or abuse, but felt her hands tied by the regulations in place. And as she said, like moments after birth, her first child We insert panic and fear. We accuse the patients of child abuse. We cause harm during a vulnerable time and memorable time for this young mother. So we're taking what should be really a happy time and just kind of inserting this really horrific experience on top of that. And we said we don't like this. And it's something that we saw over and over again. And both of us were like, we're not at a place that we can continue to work in the system anymore. So how do we change it, right? How do we start from the very beginning to change the system that we work in? So here is kind of my story of how we build a system that we do actually want to work in. And it's a long game in three acts, okay? So act one is diagnosis. First thing you have to do is be able to say the problem exists and it's in our system. So what we did was this is one of our first papers that we published. We looked at our academic, urban academic single tertiary care center, and we looked at a year of deliveries. And we just looked at our urine drug screening rates, and we looked at the hotline to the Child Protective Service rates, and we looked at why people were ordering urine drug screening on the delivery population. And similarly, mirroring this national data, and should surprise no one, right? A huge number of our patients were actually undergoing urine drug screening. More than 1 in 5 patients coming in for delivery was urine drug tested. The Black patients of our institution made up the majority of those who were tested, but they were a minority of our deliveries. So that disparity in equity is very clear in our own data. And when we looked at the indications of like why people were sending urine drug screening, our Black patients had a 2.6 higher odds of testing just due to a history of cannabis use. So they said, I use cannabis, and people are like, oh, that's a gateway drug for other dependents. We have to drug screen you to make sure that your baby isn't exposed to other substances, right? However, when we looked at the data, those folks, Black patients who delivered with us, actually had lower rates of positivity for any other substance other than cannabis. So this indication really stood out to us as sort of a inequitable sort of, etiology of kind of who was being screened and what their results were coming out as. And we looked at the hotline rates from our own urine drug screening. So if we test somebody for just cannabis use, 1% of those patients were testing positive for any other substance other than cannabis. But again, similar to that national data, 90% were being reported to CPS for cannabis use, which huge resource, sucking sort of process where our social workers were getting involved, the state was getting involved, reports were being filed, but really nothing was being, comes out of that. Really a huge waste of people's time. And so this is kind of our first stab where we said, we need to rethink this. We're showing you what is happening in our own institution, where this indication and these urine drug screens are really probably causing, not probably, but for sure causing a lot more harm than any benefit that we can detect. So, we found that peripartum urine drug screening is overutilized. Black patients experience a disproportional rate of testing, and this history of cannabis use really drives that low value and sort of inequitable testing. Which brings us to Act Two, right? So I think it's really important, especially I don't know how many folks here do any sort of research. It's really, in someone who kind of researches and works in the space, it's really important to point out the inequities and the disparities that exist. But I feel like it's really frustrating for me where that's kind of where everything ends, right? We point it out and then there's like no further action. And we've been pointing out these inequities and disparities for decades, right? Like 30, 40 years ago, these are not surprises in the healthcare system. We have to move on from pointing them out. We have to fix them. So how do we fix them? So that was our next step was treatment, Act Two of what we did. So we essentially started a pilot QI study. We belong in a healthcare system of 7 different delivery hospitals. We're the central sort of academic site. And so this was a pilot study just at our central site. We did a pre-post interventional observational study where we really kind of pulled together a urine drug screening equity team. And this kind of, circled around three big sort of interventions that we had. So one was pulling in all of the important stakeholders for education and leadership discussions. That obviously included the obstetricians, the addiction medicine folks, and the pediatricians. But what surprised me and was a huge learning point for me was the sort of pulling in of lab medicine that was incredibly, incredibly helpful for us because they could access data really, really fast. And as a clinician, I don't think of lab medicine as like, people behind the lab. I just think, oh, I'm going to send them like a CBC or I'm going to send them, whatever lab tests and they're going to run it. But there's people behind all of those lab tests. And as it turns out, they care very deeply about the equity and sort of the outcomes of the labs that are being ordered and what those results, do for patient management. So they were incredibly, incredibly important and critical to this discussion. We underwent formal policy change where included, required verbal consent for urine drug testing of anybody who's pregnant, and really try to come up with a evidence-based order indication set that got baked then into a clinical decision support tool. So every time you ordered a urine drug screen, it popped up in our EMR. You had to, select sort of like what we ended up with as sort of more evidence-based reasons to do a drug screen on someone. Evidence-based slash regulatory based. I should clarify because there were certain indications that were required by sort of hospital lawyer interpretation of state and federal laws. So specifically, the two that we got rid of completely was history of isolated THC or cannabis use and limited prenatal care because those are such, we knew the cannabis use itself was not useful. And limited prenatal care really was such like so entrenched in social determinants of health that we didn't find that it was very helpful in the prelim results that we looked at. So this is kind of what we settled on. And we made it go live. And this is kind of what we found. On the top graph there is our urine drug screening rate. So there was a significant decrease in the pre and post time period. You can see kind of our numbers there. And the disparity between Black and white are shown as well. So we were screening 23% of Black moms and 11% of white moms prior to this generally straightforward change in our indications. And after that number dropped for both, but really closed the disparity and difference gap between Black and white moms. And in addition to that, when we looked at the CPS hotline report, that similarly dropped. So prior to this change, we were calling CPS on 11% of our Black delivering moms and 6% of our white delivering moms. And that number dropped again post as well to 4 and 3.5% with no significant difference. So this made a huge difference in terms of who was undergoing a urine drug test at the time of delivery and who we were calling a CPS, filing a CPS report on. And this is something that we published in JAMA Open Network. We also looked at as balancing measures, right? Just to reassure everyone, like we weren't missing like a huge cohort of babies that we would have like otherwise identified as like needing extra support, et cetera. So we looked at neonatal outcomes and really saw no difference in any birth or delivery outcomes, whether that's preterm birth, APGAR scores, birth weight, NICU admission, length of stay, or withdrawal in the pre and post time periods. And we also looked at what I think is important to help convince people that we weren't missing cases was the number of positives for non-cannabis results, right? So some people are like, okay, so you're like limiting what you're detecting, and so you're like missing a bunch of cases. But really, there was no difference. This was a much more sensitive and specific test because we were still detecting and picking up the same number of non-cannabis positives in the pre and post time periods. And so our key findings from Act Two were that data-driven interventions really significantly reduced urine drug screening and CPS rates. Racial disparity was closed for both of those things in the post-intervention time period. And we were able to preserve clinical outcomes, and other sort of clinically relevant detection was unaffected in the pre and post time period. So we felt pretty good about that. But I think importantly, when you do it in one place, you want to say, can we do this elsewhere, right? This was so important in our academic center, but could we translate this to the non-academic healthcare settings that are in our healthcare system? So I'm going to tell you a little bit about Act 3, which is our scaling phase. We just kind of finished looking at the data from this phase, so it's still unpublished, but hopefully published soon. And so here's kind of, our next step, which is this approach generalizable to different practice settings? And so I showed you this map before, which is our 7 delivery hospitals within our giant hospital system here, as is like all hospitals, hospital systems at this point. And you can see the kind of heterogeneity of the hospitals here. The annual delivery rates are ranging from a couple hundred a year up to 3,600. Baseline urine drug testing range from 99%, so universal drug screening on admission to labor and delivery, to 8%. There is a lot of racial differences in the patients who were served by these hospitals. You can see some hospitals had a majority of non-white patients, other hospitals had a very small minority of non-white patients. And non-private insurance plans, you can see, were kind of all over the place as well. So these are 7 highly different hospital settings that we're going to try this out in. Okay. So the methods were the same. We did a multi-site now pre and post study, and the intervention was the same, just on a much different, bigger scale, really at the systems level. And I'll have a slide on this, but this was hard. This was really, really hard. And this involved, it was hard in many ways, but one of the big ones that was eye-opening for me was, I'm just like an OBGYN trying to like do the right thing, but the perception of the academic center at the smaller community sites was, fairly negative in a lot of ways, where research was like a dirty word almost. And so this required a lot of relationship building and stakeholder engagement with the leadership teams that existed at every single delivery site on both the PEDS and the OB side of things. We also standardized the urine drug screening policy across all 7 hospitals. We deployed a systems-wide order set. So the same one that we had at the pilot site, we deployed it across all of the EMRs at all 7 hospitals. We wanted to also look at urine drug testing, urine drug screening, CPS rates, racial parity, again, neonatal outcomes on this much bigger scale, and the costs that were associated. And so these are our results. You can see that the drop in urine drug screening across these 7 hospitals were universal across the board. Total overall on the very bottom, you can see it was about a 29% urine drug testing sort of rate at the time of delivery across the system. So this is a system that delivers about 10,000 deliveries a year. So kind of that's the scale that we're talking about here. And we essentially cut down with a relative rate reduction, about 90% across the entire system of who is being drug screened at the time of delivery. We looked at neonatal outcomes. So these are pooled interrupted time series from all 7 hospitals for each of these outcomes. And in terms of, maternal urine drug testing is shown up there, but the middle kind of section shows your neonatal outcomes. And there was really no difference in the pre or post time periods for each hospital. The only difference that was significant was the 30-day neonatal readmission rate that actually decreased over the 2 time periods, likely unrelated, we think, to this intervention, but That was really the only significant finding that we had in this cohort. And there's no difference in the median hospital stay as well for the neonates. So fairly robust data now on the neonatal side to show that there wasn't a huge difference in outcome. There is no difference in outcome, not a huge, zero that we could detect. And when we looked at racial parity, it really improved across the system. So this is all of our data sort of stratified by month or kind of broken out by month over time and stratified by race, so Black and non-Black individuals. And so, it's pretty visually striking. You can see the difference in terms of screening rates for Black and non-Black individuals. So and this is one of those such like important reasons why you need to look at your own data. We were screening more than 40% of Black moms or drug testing more than 40% of Black moms who were delivering in the system, which is, in hindsight, just horrible. But this is information that from the system that you would not have unless you looked at it. And then, this is using white patients as a reference. And then in the post time period, that gap really closed. So for our Black moms, that dropped to about 5%. Multiracial moms dropped to about 4% with no detectable difference between them and white moms. We essentially eliminated CPS reporting for cannabis only positives across the system. So that's in the blue squiggly line that you can see. Started out as the highest reason why a CPS report was opened. And we were able to essentially eliminate that as a reason for calling CPS, across the board. And when we look at this in terms of direct savings, this is just looking at the urine drug screen assays themselves. It's about $280,000. It's not like $1 billion, but it is a significant chunk of money during a time period where we're all thinking about how to sustain and control costs in the hospital setting. And this also does not include things like the administrative support it requires to make all of those CPS calls and the downstream effects of state, costs in terms of all of the DCSF and CPS, administrative needs as well. So the key takeaways from this data that we found was actually this QI intervention is extremely generalizable. It's dropped across 7 completely different hospitals. The patient safety seemed to be maintained across the board. Racial disparities improved, and it's a substantial, direct cost savings as well for an entire hospital system. What we're working on right now is to really piece out like, why did this work? I don't know if anybody here does big hospital systems wide, implementation QI work, but it is hard. It is really hard, right? Even at one hospital, it's kind of like you're steering this huge battleship, you're like one person trying to like steer it in either direction. When we did this at a systems level, it was like trying to steer like 7 fleets of battleships, like as one person just trying to steer them all in the same direction. And it can be like really, you can get really pessimistic and cynical when you're trying to do this work. And we're I'll be honest, a little astounded at how well this particular sort of intervention worked and this initiative worked so much. So, we're trying to piece that out right now. I think going systems wide, like I alluded to, was really hard. It was 2 years of work between the pilot site start to the systems overall go live. And what it took, again, like I said, was like really extensive multidisciplinary policy discussions. What kind of worked in our favor to have on the ground was a joint EMR. So we use Epic, and that is used across all 7 hospitals. So that's huge, right? Like whatever you touch in the EMR is going to happen across all 7 hospitals. I'll get to why I think it's not actually huge as we would think in a little bit. And we also had a women and infants sort of systems service line identified of medical directorships across all 7 hospitals. So that infrastructure kind of already existed. We weren't trying to like cat herd, a bajillion OB and peds practices across the system. So we had some infrastructure in line. We spent a lot of time, a lot of meetings, a lot of time, face-to-face time with stakeholder engagement across all seven HSOs. There was a lot of executive discussion, legal oversight, and buy-in from systems leadership. And we were able to really pull data with the help of our lab medicine folks to see the baseline practice variation quickly and iteratively across the system. So these are all really important things to make this work. And this is what is fascinating to me is that it's not like we just made the clinical decision tool go live in our Epic EMR and the change happened. It actually all happened before we even went live in the EMR. And so you can kind of see this. It was an asynchronous change in terms of urine drug testing and who is being tested across all seven hospitals. Our pilot site, which was the first to go live, is on top there. So that's the pilot site live date. And then the second dotted line, the vertical line, is when the systems-wide Epic order set went live. So you can actually see here the change, like the time point of change by the data actually occurred across all seven hospitals prior to the clinical decision tool actually being live. And this is what's like really fascinating to me, and I think something that we need to delve into a little bit more is change in a hospital system to me seems social. More importantly, seems social rather than technical. And it really suggests that like a CDS or a clinical decision tool or some sort of like EMR support is support. It's what's more important than that is the socialization and the stakeholder engagement that happens like in preparation for it. Especially for something like this, where everyone was really on board before it went live. So kind of this is like my schematic of like your typical model where we think like, okay, the clinical decision support comes out, you deploy it, and then like the person is changed. And we're like, we've changed everything because of this, right? Like actually, maybe it's the hospital and the system changes first and says, this really needs to change. Let's develop a CDS to help us change. And then you deploy it. Like this is the way to make lasting change and important, significant change in something like this. So my take pearls and takeaways from all of this is people have asked me like, how could you do this? It's so hard, especially early on. I actually didn't know if we could do this across the system. We found a lot of resistance at first within our own pilot site. I think our pediatric colleagues were really anxious, some of them, about missing, babies that could have been affected by this. And then after we went live at our pilot site, we found a lot of resistance at some of the other hospitals who said, your urban tertiary academic site does not represent the population that I see here. Your results are not generalizable. Like our moms are just different. Like what was really important for us is that we had to assume good intentions. Like we have to say, like, we are all good clinicians. We are here to do the right thing. And when we show people the data, they're going to react to it, in a good way. And it required us to have faith in the system, which is hard sometimes, but it requires you to have faith in the system that it wants to do better and it wants to change. Like if you can't have that as your sort of horizon, you failed before you've started, right? Like you have to believe in the ability of a huge system like this to change. You have to go beyond describing inequities, right? Like during our dark moment on labor and delivery, when we were just like kind of broken by this policy, we could have just said, let's just, shame the hospital and just like show them how bad this like data is and just like feel better about ourselves that we like showed off how bad and inequitable this data is. That would have maybe felt better for 1 second, but changed nothing. And I think it was really important for us to think about who we wanted to be involved in that data collection and analysis and dissemination, because we obviously took the next natural step of trying to change. We have already talked about how multidisciplinary representation was critical to our success. And lab medicine was kind of, for me, the dark horse that really showed up and really was critical to us being able to make this successful. Four is that a CDS, even though we think of that as like the easy button for all of us to push to make change like this, it was actually neither necessary nor sufficient to make this change. The socialization was the most important thing, and the relationship building was the most important thing. And lastly, I think the fact that this became policy, not at one hospital, but across the entire system, was incredibly beneficial for sustained change. And so, kind of in this timeline, we capitalized on the moment, we involved with stakeholders, we utilized research to really show the data. We socialized it, and it required a ton of patience, time, patience, and perseverance. Again, eye on the horizon. Like I have faith that this will change to make this happen. Um, I have to acknowledge this multidisciplinary team, like I talked about. These individuals, you can see how many people are here and how many people I just have names listed that were involved in this project across our hospital and all the rest of the hospitals in the system. But these people really believed in that horizon with us and really pushed for this to happen. So, you know, it takes a village, truly, for this type of change to happen. And I think I'm happy to open it up to questions at this point. And again, like how do you do something like this? It's, how do you eat an elephant? You can only eat it one bite at a time. And so it's like that setting your own expectations of your patients and understanding what that sort of the length of that journey and the perseverance that you need to make it happen is critical. So I'm happy to open this up for questions and discussion, and I'm curious to hear everyone's thoughts.
Thank you so much, Jeannie. That was really, I'm so impressed. Like, just really great work. To take something on like this, let alone actually carry it through and not give up. I mean, that's just the tip of the iceberg. So I know I'm probably speaking on behalf of a lot of people. Just thank you for showing us that this is possible. I don't know about other people, but I'm assuming there's others on this call who have maybe started to try to do this at their own institution, but we've been met with a lot of barriers and you get tired, right? And you get knocked down, and then you find, I don't know about for you guys, but I will find a partner in crime, be like, okay, now today we're going to make this happen. And then something happens and that partner can't help you anymore, and then you lose hope. So I'm really motivated and encouraged from your work. So thank you for that. So please, if you guys have questions, please raise your hand on the Zoom, or you're welcome to put one in the chat. And then we will go through people's questions. I'll get things started since I don't see anything in the chat. He started to talk a little bit about this, but I was really impressed by your like time series data or whatever you want to call it, where had your lines and when you put the pilot versus the system wide in, and you started to see the changes before. I'm assuming the bigger line on the right was the CDS that was put in place, I'm assuming. So I just want if you could talk a little bit more about maybe some tangible things. Yeah, I know you said relationships, 100% get that, but maybe some examples of some tangible things that were occurring between time point one and time point two that you can say, oh, look, this is probably something that contributed to this initiation of change before kind of like the big thing, which was the CDS.
Yeah, I think you've hit on like the heart of like for me that is like the most intriguing and most important thing you want to like I want to ask from this, right? Is because we obviously don't want to just stop here when it comes to systems alignment for work um, in this space and other spaces across the board. Um, and so, one of the things that we're looking into right now, so our pediatric hospitalists rotate through multiple hospitals.
Mm,
Not all of them, not all seven. So like the WashU, the academic hospitalists for the peds side, rotate through some of the bigger hospitals where there's lots of deliveries. And the first site that was not the pilot site that had a clear change in their testing practices is the site that's most aligned with the academic site in terms of OB, like we go there as MFMs for consultation in high-risk pregnancies, and PEDS is there as well. So I think one of the most important things that I learned about peripartum drug screening is that pediatrics actually probably drives the policy and the procedures at the vast majority of labor and deliveries. There were actually lots of barriers for me as, vice chair of obstetrics at WashU. I had a lot of barriers going into these smaller hospitals to try to, push on the OB side, lead on the OB side for a variety of political reasons that, we all have in our systems. So we actually did nothing on the OB side to disseminate or implement these new policies across the board. But I think it's because urine drug screening is such a PEDS-driven practice on most labor and deliveries. And the fact that the PEDS team from the academic center, that core group decided this is the right thing to do. Like we had buy-in from the PEDS team there. It kind of naturally disseminated out, from their team across the board. And I think obstetricians were like, thank God,
Mhm.
like we're just so happy that we don't have to drug test our patients anymore. And they were like along for the ride, like
Mhm.
whatever, reason they didn't have to drug screen someone, they were happy to do. Because it really destroys your relationship with your patient when like you're talking about that and to someone in labor, right?
Mhm.
So that was like a really important point for me. And then there's, if you look at the data, I probably can bring up the slide. We had one site that was doing universal testing across the board, um, just drug testing everybody, upon admission for delivery. And that's really a practice that we have sort of told them is not best practice for a decade, at this point. And it's really fascinating to me because they were the hospital that made that inflection point later in the sort of between, pilot site go live and systems go live. They were on the later side, but they still went live or they still changed their practice, completely changed their practice, well before the EMR forced them to. And I think it's just like such an interesting study of sort of your early adopters and your late adopters. Like some tipping point happened at the hospital when they had to look at all of the other hospitals who already made the change in the system and say, hey, like it's actually okay. Like this change seems to not cause harm and maybe have benefit. And that was like, it was, 1 month is like all it took for that change to happen. But I think when you're thinking about this sort of change across multiple diverse heterogeneous settings, like you have to say like, there is no easy button. There's not change that's going to happen overnight. People change in different times depending on the culture, their risk aversion, what, their personal experiences, etc. But again, I think it's just you have to believe that that change is possible.
Mhm.
So yeah, it's like a,
Yeah.
huge question of why that happened.
Yeah, I started with a small one, didn't I? Okay, there's another question in the chat about cannabis, and you definitely touched on that, and that data, those findings are quite striking. And so tell us, if you could tell us a little more about the backdrop of your state with regards to cannabis laws, and
Yeah,
what's been going on in the background regarding cannabis use in and also cannabis use in pregnancy that may have contributed to some of those findings potentially.
yeah. So we legalized cannabis here in the state of Missouri, like 2, 3 years ago now. It's been a couple of years since we legalized cannabis use. And then St. Louis, Missouri, for those of you who are geographically uninclined, like I was when I moved here, I had no idea where I was in the United States, but is right on the border of Missouri and Illinois. So Missouri and Illinois are very different states, as it turns out, in terms of all things. And Illinois had cannabis legalized for a long time. So there was this like disconnect of if you were using cannabis, but you had a medical card that it was prescribed to you, usually from Illinois, like you didn't get called for CPS. But if you were from Missouri and you didn't have a card, you did get CPS called on you. So that was also happening in the background. And you can imagine, even when it was legal, who had access to that medical card to say that this was prescribed to me versus not prescribed to me. That inequity of access also played out in who got a CPS call. And then what was the second part of that question?
If there's anything going on in your community with regards like public health campaigns, et cetera, about cannabis use and potentially in pregnancy that you think might have contributed to some of your findings.
Yeah, I think it is this is kind of a national sort of trend where I think cannabis use is just increasing, especially in the younger and reproductive aged individuals, where it's really just seen as more natural and more safe. So we have a lot of cannabis use here for especially for pregnancy symptoms like, oh, my appetite's really bad, so I'm going to use cannabis to like help, or I have a lot of bad nausea, vomiting, in early pregnancy. So like, instead of taking your scary Zofran, I'm going to take cannabis because that's more natural. So, if we do have campaigns that are losing, any sort of public messaging about cannabis use, especially during pregnancy. But it is we absolutely see a growing problem in our population.
And then maybe I might have missed this, but clarify with me, before this project, did you guys have that order, like the indications before this project? So was the order itself completely new?
Mhm.
Okay.
Like
And
the
so
urine drug test like wasn't new, obviously, but that hard stop of like
answer question.
selecting, I got consent, and here's my indication did not exist before this.
Okay, because our other question is about like eliminating the option to do the drug test based off of limited prenatal care
Mhm.
first, and then that was that one and the cannabis only. I'm not sure if you could speak on which of those indications might have driven more of your impact since you didn't necessarily have that before.
Yeah, it was definitely the cannabis use.
Okay, or you can say it.
Yeah, it was a hard, yeah. Like the limited prenatal care we got rid of because there's no accepted definition of what limited prenatal care. It was like vibes, and you cannot go off vibes when it comes to urine drug testing during like pregnancy, right? So there's no accepted standardized definition of like what normal limited prenatal, what the difference is between the two. And obviously both of those things, like how much access you have to prenatal care or even know that you're pregnant is deeply steeped in social drivers of health. So we got rid of limited because we nobody actually could tell you what that meant as like a reason why. So we changed it to no prenatal care because that was like a more black and white sort of fact that you can find out about someone. But that was a minority of the cases. It really was the cannabis use. And I think that was like the importance of that first sort of act or that first paper was to show like, hey, like when someone tells you they're using cannabis, like their urine is going to confirm that like you found out no new information.
Mhm, mhm. Great. Well, I don't see any more questions in the chat. Does anyone have any questions that they would like to ask Dr. Kelly?
I have a couple questions. Um, I'm Camila Arnato. I work in Indiana. I'm a perinatal and addiction psychiatrist,
Mhm.
so right next door. And I guess I have a couple different questions. One is what gets brought up here, in addition to the neonatal specialists, really hesitating and worrying that we're gonna harm the babies by not doing the tests. So I would love to hear about that and sort of how you approached talking to them. I don't find that data always sways that situation because they are very entrenched in their belief that
Mhm.
it's wrong to not test. And then my other part, because you mentioned legal. So the other thing that gets brought up to us a lot is around fears of not complying. And
Mhm.
so if you can talk about like working with the legal team, talk.
Yeah. I think those are like two just, critical questions and critical components of why this worked. Like you alluded to, like it's a lot of deep-seated anxiety and fears about missing a critical finding in a newborn and missing that, right? I'm not a pediatrician, and I'm not part of like DCSF of our state, but I can only imagine how hard that job can be if you miss something and some horrific case comes in to the emergency room or kind of via whatever avenues. Like I can only imagine how hard that is, to be in that place to have to make those determinations. That being said, I think what was crucial was finding a champion on the peds side, to really say, hey, I'm a pediatrician. I speak the language that you speak. I know the anxieties that you have. This data is important, and this data shows us that we're doing the wrong thing and causing harm without any benefit. And I think finding that person on our peds side, and actually finding multiple of those champions on the peds side, and having them in places, being elevated to places of leadership within the peds team, was crucial to being able to convince other pediatricians that this is okay, this is safe, it's okay to change. You can see that like because it took so long, 2 years, that some places were easier to convince than others. And I will say, like on the NICU side of things, these are hospitalists for newborns, mostly term healthy pregnancies, right? On the NICU side, like we still have an uphill battle that the urine drug testing screening battle has been sort of changed at this point, but breastfeeding is a big battle that we're fighting right now between the newborn hospitalist side and kind of the NICU side and there's different policies, right? Which we hate when there's different policies in different places at the hospital. So I think finding a champion, one, hopefully more, uh, is critical in that specific specialty. Now, in terms of legal, we actually had our general counsel, and our general counsel is very intimately close to the OB team here in Missouri. But we had them review changes of the policy to ensure that we were, crossing our T's, dotting our I's. And that involved the sort of academic general counsel, so, my team, but also the hospital systems general counsel, which is like a totally separate team, and having them come to an agreement that whatever change we had was in line with state and federal, regulatory requirements. And once that was signed off on, we were like, legal said it was fine. Legal said it was okay. Like everyone's fine. And that, that was after that was a moot point, when we can say like legal from both sides is cool with this change. So I think those are two critical components that you have to align before any of this change can happen.
Thank you. And right there with you on breastfeeding. That
We're still working on it.
Well, we're at time, so thank you so much, Jeannie. This was wonderful. You gave us a lot of great, things to work from and encouragement. So thank you so much. And great work. I'm so glad you got that first paper out. I'm assuming you're going to follow up with another one to get this out to motivate some others too. Um,
Yeah, hopefully, yeah. That's the goal.
yeah, please do. Please disseminate this so it can be shared. I think it's great work, and I think a lot of people would find it extremely impactful. So
Well,
thank
thank
you.
you all so much.
Yeah.
Really appreciated this opportunity to share.
Awesome. Thank you guys all for coming. This will be posted and I'll send out the link. And then please mark your calendars for March 27th, which is exactly 4 weeks from today for our next journal club. Have a great weekend, everyone. Bye.
Thank you.